This program is brought to you by Stanford on iTunes U at Stanford University. Please visit us at itunes.stanford.edu.
What I'm going to do tonight is just give you a little bit of a tour through the past 50 years of history in how the worlds of engineering, science, and medicine have converged to really make a substantial difference in the care of children who have heart problems. And so the question that many of you may ask is, why are we even bothering to talk about heart disease in children? Most people would think that heart disease in children is actually quite rare. In fact, congenital heart disease is one of the most common birth defects, and it occurs in nearly 1% of infants. So it is a fairly common problem. More than that, it is the leading cause of death due to all birth defects, accounting for about a third of all deaths due to birth defects. So it is still a serious problem. Even in the year 2005, when we have all these wonderful technologies, it still represents a major challenge for many families. If you were born in 1950 and had a congenital heart lesion, a small hole between the two upper chambers of your heart, or a hole between the two lower chambers, very common defects, the chances are that you probably would have had a very, very perilous childhood. You might not have even lived beyond the first couple of years of life, and if you were lucky enough to survive the first couple of years of life, the chances are that you would develop a condition called pulmonary hypertension by the time you were a teenager, and the chances of you living beyond 15 or 20 years would have been pretty small. Then, in 1954, a group of pioneering doctors, this is at the University of Minnesota, and actually Dr. Norm Shumway, one of the pioneers of transplant surgery, was part of this team, did the first open heart operation, and this was done on a young child with a hole between the two upper chambers of the heart, something that today would actually be a very, very simple procedure. And this was a real example of pioneering teamwork, because in this room there were surgeons, nurses, cardiologists, anesthesiologists, all working to do a very, very new procedure. What you probably didn't notice when you first looked at this slide was this other patient off in the corner there. Well, that actually was the little girl's father. Because this was done in the days before heart-lung machines were developed. And so, in fact, the only way that one could open up the heart and repair a hole was to use the father in a procedure called cross-circulation. So they actually took the blood from the father's arteries from a set of tubes, pumped it into the baby. The father provided oxygenated blood for the baby's body. The baby's blood then returned to the father to pick up oxygen and get pumped again. Today at Packard Children's Hospital, we do like to involve parents in patient care. We call it family-centered care, but we don't usually go to this extreme, although we sometimes do. And there are procedures, for example, living-related organ transplantation, where we take a lobe of a lung or part of a liver or sometimes a kidney from a parent or another relative and, in fact, use it for a child. So there are times when, in fact, we do involve relatives more than just as being there to be supportive. This is another example of innovation, and when I show this slide, everybody in the audience from this area looks at that and says, oh, that's a garage, I know what that is, that's Hewlett-Packard, right? Well, but you have to notice this is actually snow on the ground there, and in fact, so this is not in Palo Alto. It turned out that when they started doing the first open heart operations, they had a problem because the location of the holes in the heart was very, very close to where the electrical wires of the heart ran. And every once in a while, the surgeon would bump up against those electrical wires when they were suturing a patch across the hole, and they would cause a condition called heart block, where the top part of the heart doesn't talk to the bottom part of the heart. And in some of those patients, the heart block would resolve after a couple of days or a couple of weeks, and the patient could go home. The problem was that this was before the era of pacemakers. And so if you had heart block, you couldn't get the patient out of the operating room because there was no way to keep the heart going until this condition resolved. They invented a pacemaker that had to be plugged into the wall. And so when Dr. Lillehei and his colleagues were first taking patients back from the operating room, they had these long extension cords, and they would wheel the patient down the hall, and they'd wheel this apparatus, which was about the size of a refrigerator, alongside the patient. And then the orderlies would have to quickly change the plug from one extension cord to the other. And of course, they could never take the patient in an elevator because there was no way of being able to power this device. So the surgeons said, well, there must be a better way. And so they approached the hospital engineers and they said, well, you know, we can't think of a solution. But the head nurse in the operating room said, you know, every time I really have a problem, I go down to that television repair shop down the street, and those guys are great. They fix anything. Turned out that that month, the first transistor project ever to be published in Popular Electronics came out. And it was a metronome, and it was actually on the cover of Popular Electronics. And when Dr. Lillehei went to talk to these guys in this television repair shop, they said, well, you know, a metronome, that tells time, doesn't it? And, you know, a pacemaker is probably not that different than a metronome. All we have to do is kind of get the voltage up a little bit higher, and maybe we could come up with a transistorized pacemaker. Turned out they did. That company that developed this first pacemaker ever is now called Medtronic. It's one of the largest medical device companies in the world, and it's the leading pacemaker company in the world. This is an example of collaboration between engineers, medical scientists, to come up with a new paradigm. Open heart surgery for the first time, and being able to actually pace the heart to keep the patient alive. I'd like to now tell you about how some examples of new paradigms or paradigm shifts have occurred over the last 20 years in terms of the diagnosis, etiology and prevention, and treatment of heart disease in children. Well, let's talk about diagnosis first. In the early days, this was the way we used to diagnose congenital heart disease. You used X-rays in a procedure called a cardiac catheterization, which we sometimes still do to make the diagnosis of heart disease, but in those days it was a fairly risky procedure. Nowadays, for the most part, diagnosis can be made in a machine like this, a magnetic resonance image scanner or a CT scanner, or using other technologies. Back when I was in college, this is what was known as an echocardiogram or an ultrasound. And you can see these little wavy lines here representing, in this case, one of the heart valves called the mitral valve opening and closing. This is a one-dimensional look at the heart. And anybody looking at this would say, doesn't look like a heart. Well, two-dimensional echo came about in the 1980s. Now that looks like a heart. Here are the four chambers, and in fact this is a child with a hole between the two upper chambers of the heart, similar to that child who had that operation that was the first pioneering surgery. In the 1990s, we developed a new technique called color Doppler. This allows us to tag the blood flow going through the hole and look at the velocity of that blood flow and the directionality. We use this routinely now to make the diagnosis of heart disease in children. But that's old stuff. Where are we going in the future? Well, this is an example of an echocardiogram in real time. You can see the image here. These are the four chambers of the heart. This is the major pumping chamber called the left ventricle. And here's the mitral valve. You can see that valve opening and closing. Well, what can we do to make this an even better tool? So if we want to look at the function of that heart chamber, we actually have machines now that can trace out the inner surface of that ventricle as it's contracting without actually having to have a technician do that. So with image processing, we can then look at the volume of the blood in that heart chamber all in real time and look at the segmental wall motion of each of those different parts of the heart and tell, for example, whether or not someone is having a problem with coronary artery blood flow, in which case one of these segments might not contract as well, or whether they have, in fact, a congenital heart problem which is affecting the function of the heart. And this is all done now with image processing technologies that were borrowed from space-age technologies that came around over the last 15 or 20 years. We can now take ultrasound probes down to micro-miniature size. This is a coronary angiogram. This is a picture of a coronary artery, and this is a narrowing in that coronary artery due to someone eating a little bit too much steak and potatoes and not enough vegetables. Well, turns out that this is one way of making that diagnosis. We can now take an ultrasound catheter and actually put it down the center of those blood vessels, and we can actually look at the atherosclerotic plaque from the inside. So this round thing here is the catheter itself, and this white thing here is the atherosclerotic plaque on the inside of the blood vessel. And this is a much, much more detailed picture than we can see with coronary angiography. This technique was actually invented by one of the cardiologists at Stanford and has really pioneered the treatment of patients with coronary artery disease. What about 3 dimensions? Well, here's a 2-dimensional look at the heart. This is now a 3-dimensional look at the heart. Now you're actually looking down at one of those heart valves and actually seeing it the way that a surgeon would actually view it in the operating room. And this is technology that is now available routinely and it's been developed within the last 3 to 4 years. Let's go on to other imaging technologies. Everybody's heard of CT scans using X-rays and MRI scans. Well, this is an example of what those scans used to look like. And again, if I showed you a picture like this and you weren't a healthcare professional, you'd probably scratch your head and say, exactly what are we seeing there? Well, this is the heart. This is the major blood vessel leaving the heart. This is the blood vessel going into the lungs. But it really takes a lot of imagination, and we always kid our radiologists that they in fact have to have a big imagination in order to see things in one of these, because these essentially are flat plane images. They're 2 dimensions. They're not 3 dimensions. Of course, we think in 3 dimensions. All the things inside the body are 3-dimensional objects. What can we do better? Well, we can do now 3-dimensional reconstructions. So this is a patient who has a blockage in the major blood vessel coming out of the heart called the aorta. And here you can see the blood vessel coming out, and there's a big narrowing, a kink in this blood vessel here. This is a child who had an operation to repair this, but we did this imaging using CT scanning and reconstructing the scan in 3 dimensions. It's a lot easier to see that kink in this picture than it would be in a 2-dimensional picture. Here's another picture of a heart. And this was in a 12-year-old child who had an abnormal connection between 2 of the blood vessels. We can rotate these pictures around in 180 degrees. We can put the orientation of the picture in exactly the position that the surgeon is going to see it in the operating room. That way the surgeon gets an absolutely perfect view of what they're going to encounter when they get in there. So where is the future? This is what we're doing now. Where are we going with these technologies? Well, many years ago, Isaac Asimov wrote a book called Fantastic Voyage, and many of you may have seen the movie. And in this movie, a group of scientists and doctors were shrunk. They were put into a submarine, and the submarine was shrunk in size until it was microscopic in size, and then the submarine was injected into this person's body. And then, of course, in this movie, they're flying through the bloodstream, and there's white blood cells attacking them, and they had to get to this person's brain to destroy this brain tumor from inside the body. Well, that was science fiction back in the 1960s. And so the question is, can we take a couple of heart surgeons and shrink them down and put them into the body in order to make the diagnosis of heart disease? Well, we don't have to do that. We can use a technique called fly-through CT imaging, and this is what that looks like. This is using a CT scanner. We're actually inside this patient's heart, although there's not a single catheter in this patient's body. We're now going down to the base of the left ventricle. You can see the coarse trabeculations, or the muscle fibers lining the ventricle. And here we're coming up now. Here's the aortic valve, the main valve connecting the heart to the body. You can see one of the leaflets here. This patient only has 2 instead of 3 leaflets. That's an abnormal valve. Here are the blood vessels going up to the patient's brain and to the left arm. And now we're swinging around, and we're going to actually see a hole between the 2 large blood vessels coming out of the heart, the aorta on one side and the pulmonary artery going to the lungs on the other. And as we swing around through here, you're going to actually see the aorta up this way, and then the pulmonary artery going to the lungs this way. This is called fly-through imaging. We're in that submarine flying through this patient's body, but in fact this is all done using an external scanner and highly sophisticated computer reconstructions. And we use this now routinely to look at abnormalities in the blood vessels in both children and adults. Let's move forward to what causes congenital heart disease. Now we can diagnose it. Wouldn't it be great if one day we could actually prevent heart disease in children? Well, prior to 10 years ago, if you came and asked me what causes congenital heart disease, if one of those 1 in 100 families came to me and said, my child has born with a heart problem, what caused this heart problem? Was it my fault? Did I do anything during the pregnancy? We would have said, you know what? We don't know. It's what we call multifactorial. There's probably a genetic component and there's probably an environmental component, but a lot of it we don't have the answer. Well, that was because we just didn't understand enough. It turns out now that we're beginning to recognize through projects like the Human Genome Project, where we are now beginning to map every single particular gene in human chromosomes, we're beginning to understand that many of these congenital defects, in fact, are due to specific gene abnormalities. And as we learn more about the development of the heart, we may be able to one day test people with a simple blood test. For example, both parents have a blood test to see whether or not they carry a mutation which could lead to congenital heart disease. What are we doing? What are some of the technologies that are allowing us to do this? Well, one is molecular diagnostics. That is, how do we begin to fathom which genes are causing which problems? Well, if I think I have a gene, we'll call this a particular gene of interest, that I think might cause a congenital heart problem, I can look at a control patient, and I can look at a patient who has a disease and see whether or not there's a difference in the amount of that gene. So where you see a black spot here, it means that the gene is expressed in high numbers, and when you see a white spot or nothing, it means the gene is expressed in low numbers. This had to be done in a painstaking process, one gene at a time. Well, we now know that we have 33,000 different genes. How can we possibly learn anything if we have to do things one gene at a time? Well, it turns out that using the same kind of technology that we use to make computer chips, we can make something called a gene chip. And again, this was a technology that was invented by a scientist by the name of Pat Brown at Stanford. And what these gene chips are is just like a silicon chip, we can take a little tiny piece of DNA and put it on a little tiny microscopic spot on a chip. And we can fit 25 or 30,000 of those little pieces of DNA on the chip at one time. And then we can take a sample from the patient, and we can see whether or not any of the patient's DNA matches the DNA that's on the chip. And it essentially allows us to come up with a map of up to 25,000 different genes all at the same time. And using this, we have now been able to look at large groups of patients with congenital heart lesions and begin to understand which groups of genes may be involved in causing those lesions. And for the first time, we're beginning to identify a group of specific gene malformations sitting on specific chromosomes which cause certain heart defects. This is still in its infancy, but this has all been done really within the last 5 to 7 years. And this technology is just beginning to be expressed. So I think if I come back and give this talk 5 or 6 years from now, I would have a list that would go on and on and on. Where else can we use some of the benefits of the Human Genome Project? Well, there's another field that's very exciting and something that's probably going to touch every single one of us, and it's called pharmacogenomics. When I give you a drug, 90% of the time the drug is going to work pretty well. You're going to get better. In about 5 or so % of the times, the drug is not going to have any effect at all. We don't know why that happens. And then in another maybe 5 or 10% of the times, the drug is going to cause a complication. And then every one of you has heard those commercials on television where they say, this is the best thing, take the purple pill, it's the best thing in the world. And then afterwards they tell you for 10 minutes what the lawyers want you to know, which is that it's going to make your head fall off and your right arm go numb and you're not going to be able to see and all these complications. Why is it that a drug that works so well in most people causes complications or has no effects in other people? Well, we used to say we didn't understand why these idiosyncratic reactions would happen. It turns out that it may be the interaction of those drugs with the host that's taking the drugs and the particular genetics of that individual. And let me give you an example, and this is from research that we do in our laboratory on a particular protein that sits on the surface of all of our cells. This is a picture or a cartoon of a heart cell, and on the surface of that cell sits something called a receptor. And a receptor is like a lock. And a hormone, in this case adrenaline or epinephrine, comes along in the bloodstream and fits like a key into that lock. And when that hormone fits into that protein, it causes a change inside the cell. In the case of a heart muscle cell, it means that there's more calcium available inside the cell, which makes the heart beat faster and stronger. So when you go out jogging, your adrenal glands and your nerves produce more adrenaline, which goes through your bloodstream, binds to this lock called the receptor, and that causes your heart rate to speed up and to pump more blood. Well, that's all well and good for a short period of time. On the other hand, when you have a heart disease, like heart failure, your body is making adrenaline all the time. And patients who have high levels of adrenaline, actually, this hormone, when it constantly bathes this receptor, can cause damage to the heart muscle. This process is great for short periods of time, like going out jogging, but is really bad when it's there all the time. And that's led to a class of drugs that you've probably heard about called beta blockers. Beta blockers are used to block the effects of these hormones on the heart muscle and prevent some of the damage associated with heart failure. And these are now commonly used in many, many patients with heart failure, and they're very successful drugs. The interesting thing is that they don't work in everybody. And in some patients, they cause the heart failure to get worse. The question is, why is that? It was interesting that when these drugs were tried in large clinical trials in Europe, they always worked. But when they were tried in the first clinical trials in the United States, they only worked some of the time. And it turns out that when they began separating out the results on patients in the States, it turns out that people of different ethnic backgrounds responded differently. Well, why is that? Well, this is what a protein looks like. Protein essentially consists of a group of amino acids, and in this case, this protein is that receptor, and it has a huge number of amino acids that weaves its way through the inside and outside of the cell 7 times. And what happens is that the hormone comes in and identifies these loops here, and then that's what is that kind of key in the lock. Well, it turns out that everyone in this room doesn't exactly have the same amino acids in their protein. Some of us have one different amino acid compared to the rest of us. And that's called a single nucleotide polymorphism, or a SNP. Now, you may say, well, wait a minute, if you have a different gene, isn't that a mutation? Isn't that something that causes a disease? We know that, in fact, if you have a single gene abnormality, a single amino acid wrong with your hemoglobin gene, you have a disease called sickle cell anemia, which is a severe disease. Well, it turns out that if you have a single changed amino acid that causes a disease, we call it a mutation. However, if you have a single amino acid change that doesn't cause any disease, we call that a polymorphism. It's just a difference between different people. Well, it turns out that, for example, at this location, this is amino acid number 164. So if we count down through this protein, number 164, 95% of us have an amino acid called threonine at that location. But 5% of the population have a different amino acid. It's called isoleucine. What does this do? Well, in every one of us, if we're healthy, it doesn't do a thing. It doesn't cause a disease. It is not a mutation. However, if you have a heart attack or if you have heart failure, having one of these genes, one of these mutations or single nucleotide polymorphisms dramatically changes your survival. So this is a comparison of patients who have heart failure if they have this particular gene versus this one that's, again, present in 5% of the population. At about a year after the beginning of the study, only half as many patients with this gene are alive as this gene. Suggests that, in fact, this SNP, this polymorphism, can help us predict which patients are going to do well and which ones are not going to do well. Maybe these patients ought to be put on the transplant list right away, whereas these patients can, in fact, be treated with medication. And it turns out that patients with this particular gene respond very well to the medicine. whereas patients with this one, in fact, do not respond very well to medicine. So we're beginning to learn that individuals, based on their genetics, respond not only to diseases, but also to the medications we use to treat those diseases in different ways. Patients with asthma also have abnormalities in the same exact receptor that determine how well they're going to respond to their anti-asthma medicines. One of these days, probably very soon, you will go into your doctor, have a blood test that will look at a panel of different polymorphisms, and your doctor will use that information to determine not only what diseases you may be susceptible to, like lung cancer if you smoke, like diabetes if you eat a lot of sweet foods, or heart disease if you happen to have one of these genes. And not only will he or she give you advice about lifestyle changes, but actually may use that information to determine which medications to give you if you have one of those diseases. This is called pharmacogenomics, and these technologies are here today. Let me now talk about treatment of congenital heart disease. Now again, back in 1954, that first operation was a pioneering procedure to open up the heart, close a small hole between the two upper heart chambers, and that was regarded as an extremely dangerous, risky procedure. Nowadays, those kinds of patients never even see the inside of an operating room. Well, if you have an abnormality of a valve, starting about 1985, we developed a procedure using a balloon to pop open the valve, and it's called a valvuloplasty procedure. Here you can see an angiogram. This is a picture taken in the cath lab. This is a wire, and on the wire is a balloon. And here you can see the indentations made from the valve as that balloon is being blown up, but the valve is so stiff because it's very stiff and fibrotic. It's got a lot of scar tissue that, in fact, it's indenting this balloon. We then put a little more pressure in the balloon, and we pop open that blocked valve. And this is what that looks like. Here is a before and after picture. This is some dye injected into the right side of the heart. This is the valve going into the lungs. And here you can see a very narrow amount of blood. There's a squirt of blood coming out through that valve. And afterwards you can see that that valve is now widely open. So for children who have this particular condition, we don't take them to the operating room anymore. We take them to the cath lab. The balloon procedure is done. They're cured. They go home the day after. No scars, no surgery. Well, you've probably heard a lot about stents. Stents are now very commonly used. In addition to using balloons, if you have a blockage in a blood vessel, in this case it's in a coronary artery, but we do this in children and other blood vessels as well, if you put a balloon in and expand it, the problem is that the stiff wall of the blood vessel makes that blood vessel contract again. We call that restenosis, or re-narrowing. Well, so a group of doctors invented these expandable stents, and they're wire meshes that can fit around the balloon. The balloon then expands the stent in the artery, and the stent sits in place. Now the blood vessel can't contract back. Well, it turns out that the body doesn't like having this stuff in it. Okay? And so when stents are put in, sometimes the inner wall of the blood vessel will start growing back into the middle of the stent, and we call that in-stent restenosis, a narrowing that's occurring inside the stent. Well, how is modern pharmacology and modern medicine dealing with that? Well, it turns out that there are medicines that we can give that inhibit or prevent the wall of that blood vessel from growing thicker. One of them is called sirolimus, and sirolimus prevents cells from dividing. So if you take one of these stents and you take this drug and you impregnate the stent with the drug and then put the stent in, what happens is the drug will then go through the tissue, prevent the damaged wall from regrowing into the stent, and then by the time the drug is gone, the wall is healed again, and it prevents this restenosis or re-narrowing procedure. And so now, if you read the papers about the successful use of stents in either coronary artery disease or other problems, most of them are stents that contain one of these drugs. This is a special catheter that's called an atrial septal occluder device. This is a catheter that can be put up into the heart that contains two separate discs, and the discs are separately pushed out from the catheter and form a sandwich that can be used to close a hole. Let me show you how that looks. So this is an echo, an ultrasound of a patient with an atrial septal defect, a hole between the two upper chambers of the heart. This is the left-sided atrium, this is the right-sided atrium, and here, this kind of area here, is the hole between the two upper chambers. Again, the very same heart defect that would have caused this child to die back in the early 1950s that Dr. Lillehei did the first pioneering operation on. And here now, we're in the cath lab. We've got a catheter that's been inserted in the patient's artery, in the vein in the groin, moved up into the heart, and the catheter, you can see, is sitting across the hole, going up from the right side of the heart to the left side. Now you can see the first part of that device has been deployed, so this is the first part of the sandwich. This is the left side of the sandwich that's now sitting in the patient's left atrium. With a little twist of the catheter, we now will extrude the right part of the sandwich. You can see the left side and the right side, and the catheter is still connected here. The cardiologist is watching with the fluoroscope to make sure, also using the ultrasound, to make sure that these are positioned in the right place. Oops. And then basically draws these together, unscrews the wire, and then removes it from the body. And this now closes the hole. Patient goes home the next day. The hole is closed. The body's own inner surface will grow over the metal discs so that if you opened up that heart 6 months later, you wouldn't see the metal. What you would see is a white, filmy substance, which is the normal lining of the heart, that will have grown over that area, protecting it. And essentially, this child will have their heart disease fixed without the need for open heart surgery. What else can we do with a catheter? Well, the newest technology coming down the pike is the use of transcutaneous valves. What is this? Well, if you have to have a valve replacement, that's a pretty serious surgery. That has certainly been always open heart surgery. Well, it turns out that that may not necessarily need to be the case. You can take one of those stents, here's an example of a stent, and you can actually take a tissue valve. In this case, it can be a homograft, which means a valve taken from a cadaver, or it can actually be a porcine valve from a pig or from a cow, and you can actually sew it to the inside of a stent. Then you can actually take a catheter, bring that stent and valve up into the artery that you want to replace the valve in, and essentially blow that balloon up. In the middle of that, it expands the stent, opens up the valve, you take the catheter out, and the valve is left in place. We did this on a patient of mine who was 8 months of age recently, who was extremely sick and would have been a very high-risk patient for going to the operating room. Within about 15 minutes of having the new valve in place, her heart had already gotten dramatically smaller, and in fact she went home from the hospital the next day and has avoided needing to have open heart surgery. This is a wonderful new technology, and this is now it's essentially in clinical trials right now in the United States. The problem with this, though, is that for this in adults it's great, because if I put a new valve into an adult patient, that valve may last for 20 or 25 years. The problem with putting a valve like that into my 8-month-old patient is that kids grow. And a blood vessel that is this size in an 8-month-old, by the time they're 2 years, is a little bit bigger, and then bigger and bigger. And as they grow, we have to continuously replace these valves over and over again, which means multiple procedures and multiple surgeries. Wouldn't it be great if we actually had a valve that could grow with the patient? Well, that's where tissue engineering comes in. And this is not science fiction. These are now being done in animal experiments, and there will be human trials of some of these tissue-engineered valves soon. What does this involve? It involves taking the type of cell that causes a valve to form from the inner lining of an artery or a vein in your body. So I could take a little snip of an artery and sample the cells, and I can grow them in a cell culture dish in the laboratory. And cells divide. So I can take a little sample of cells and make a whole bunch of cells. Then I can take them and put them on a scaffolding. And the cells will grow over that scaffolding. In this case, the scaffold is in the shape of a valve. But I can make the scaffold out of something that dissolves over time. So the scaffold is there only long enough to allow the cells to grow into the shape of a valve, and then gradually will deteriorate over time. So by the time I'm ready to put this into the patient, it's just natural tissue. And since it comes from the patient's own tissue, it won't be rejected. And since it's living tissue, the hope is that it will grow. And some of these valves have now been put into experimental animals. Some of them have been in for as long as 2.5 to 3 years. And the good news is if you put it into a young animal and watch that animal over time, they actually will grow. And my prediction is that within the next 5 years, these will be in clinical trials as well in both children and adults. And this will solve one of the really major remaining problems for children with heart disease, in whom every time you have to do a surgery, you're doing it because the child is getting bigger over time. Well, what happens when you can't fix something? So if you have a hole in the heart, you can fix it with a patch. If you have a missing chamber, sometimes you can bypass it. Well, once in a while, we have to replace the entire heart. That's heart transplantation. Heart transplantation has now entered its 3rd decade. We have some children who were transplanted 20 to 25 years ago. Our longest surviving child is now 28 years out after a heart transplant. And we have dozens and dozens of kids who are getting to their 10th and 20th anniversaries after transplant. What are some of the new technologies that are coming down the pike? Well, you may have heard in the news recently about this procedure. This is called a heterotopic transplant. Sometimes the patient's heart is sick, but they have damage to the blood vessels in the lungs as well. So if we do a heart transplant, the transplant won't be effective. In this case, this was a little 1-year-old girl in whom we took the donor heart and we piggybacked it with her own heart, with the recipient heart. So this little girl actually had 2 separate hearts beating in her chest, one on the left side, one on the right side. In fact, if you look at the electrocardiogram here, there actually are, you can see 2 beats here. So the 2 hearts are beating at separate times. One of the hearts, her own heart, was pumping the blood into the damaged lungs because it had been used to pumping at high pressure and could pump into the lungs, whereas the donor, the new heart, essentially is pumping blood out to her body. And this is a procedure that is being done now to prevent the child from needing a more serious and complicated operation, which would be a heart and lung transplant. What about children who are very sick with heart problems who need support while they're waiting for a transplant? Well, in adults, we have a number of different devices called artificial heart or left ventricular assist devices. And this is an example of what one of those devices looks like. We can take the blood out of the left atrium of the heart, bring it out through an external pump that sits on the patient's chest, and pump that blood back into another catheter into the aorta, and we can keep people alive. I think the longest living survivor on this device has been about 5 years. Most of the time, we use these devices to get the patient to survive long enough to get a donor heart for them and do a heart transplant. The problem, of course, with these devices is that none of them are made, or until recently, none of them were made small enough for young kids. So if the patient was less than about 40 kilograms, they were not eligible to have one of these devices put in. Well, it turns out there's a new device that we've used. This is the science story in the New York Times. But this is a little boy who recently had this device attached to his heart. And the nice thing about these devices are, in fact, that the patient can be off the breathing machine and can be doing reasonably well. Here he is with his dad. He's now waiting for his transplant with this artificial heart device. And this device is now available for use for very, very small babies. The youngest we've used has been this little boy who was about 4 months old at the time. And he got his heart transplant, and he's been doing just fantastic ever since. Where's the future? Well, you hear a lot about stem cells. And stem cells and bone marrow cells are probably going to be the solution for heart transplantation, because there's no reason to transplant a heart, in fact, if we can fix it. And so here's an example where a group of bone marrow cells have been injected into a damaged heart, and they're beginning to look like they're developing into normal muscle cells. So in fact, one day, instead of doing heart transplants, we may do just cell transplants, where we inject the cells into the heart, give a special hormone or drug that will make the cells grow into heart muscle cells and repair damaged or abnormal heart tissue. And that is being done in animals now and is something that will, it's actually, there are a few human clinical trials that are being done. So far the results are very, very, very preliminary. But keep watching the New York Times science pages, and I think you'll probably see some exciting things coming down. Lastly, I'd like to talk about a very, very interesting and exciting topic, which is fetal diagnosis and treatment. Most severe congenital heart defects can be detected much, much before birth, usually by about 17 to 20 weeks of gestation. We do approximately 800 fetal ultrasounds each year at Packard Children's Hospital. And most of the ultrasounds, of course, are normal. But when we have a mother who may have a particular high risk for having a child with a heart condition, or, for example, with a strong family history of heart conditions, we can sometimes detect those lesions before birth. What's the advantage of doing that? Well, early detection can improve prenatal care. We can make sure that that woman gets the best prenatal care and also help us manage the perinatal transition. It would be better for a child with a severe heart condition to be born at a major heart center like Stanford rather than born at a small community hospital hundreds of miles away and then have to airlift a very sick baby all the way to Packard Children's. And in fact, about a third of the babies now being born at Stanford with congenital heart disease have already had their heart disease diagnosed in utero. Well, but that's not good enough, right? You know, we're making the diagnosis and we're helping to get families prepared for it, but wouldn't it be great if we could do something to treat it? Well, this is an example of what we used to do. Again, this is the old-fashioned one-dimensional M-mode echoes. We actually have been able to use echocardiograms to treat certain kinds of heart disease in the womb for a long time. This is an abnormal heart rhythm where the heart is beating irregularly, and we can actually make that diagnosis in the womb using echo and actually then treat the fetus either by giving the mother a drug which converts the abnormal rhythm or actually putting a catheter, a needle, into the umbilical cord and delivering a drug directly to the fetus. That's been around for a while. But what else can we do? Well, here is a fetal ultrasound. This is a 29-week gestation fetus, so 30 out of about 3/4 of the way through gestation. And actually, you can see the heart beating strongly here. There are 4 chambers, 4 valves. You can see the color Doppler showing the flow of the blood through the aorta, the main blood vessel taking blood to the head and neck. This is a normal fetal ultrasound. This is an ultrasound of a baby who has a very severe heart condition called hypoplastic left heart. You can see instead of being 4 chambers here, there is only 3. The entire left side of the heart is missing. This is called hypoplastic left heart syndrome. It is one of the most severe heart malformations that young babies can have because it's impossible for the surgeons to rebuild a normal left ventricle when one is absent. So the only operations that we can do are to find a way to make this right ventricle serve as the main pumping chamber, and using a lot of bypass operations. This takes 3 or 4 operations before we can get the child to have a reasonably normal circulation. And certainly many of these children will still not live a normal, full lifespan. So wouldn't it be great if we could prevent this? Well, it turns out that if you do an ultrasound at a fetus at about halfway through the pregnancy, some of them will have a normal-sized left ventricle, but will have a blockage of this valve called the aortic valve going out of the left ventricle to the aorta. The problem with the fetus is that if you block blood flow going in or out of a chamber over time, that chamber doesn't get enough blood flow. And over the course of the pregnancy, that chamber will fail to grow and develop. And we can watch this with serial ultrasounds. If we do an ultrasound every couple of weeks on the mother, we can see the baby's heart getting smaller and smaller with time until we're left at term with the hypoplastic left heart syndrome. Well, aortic valve disease is very easy to treat. We can do a balloon procedure, open up the valve, we can put a new valve in. So if I have a newborn who has this condition, it's readily treatable. If I have a newborn who has this condition, it requires 4 complex or 3 complex operations, and it's more complex to deal with. Wouldn't it be great if we could prevent this from turning into this? Well, you'd have to be able to intervene somehow during fetal life. And the answer is there is a mechanism that is being tested now to prevent certain heart defects before birth. The New York Times reported on this back in 2002, and it called this a science fiction success. And this was done by one of our doctors, Dr. Stanton Perry. This was actually done when he was still at Boston Children's Hospital, but he's now at Packard. This is an ultrasound showing this is the mother's abdominal wall is up here, the uterine wall is here. This is the fetus, the body of the fetus, and this is actually the thigh. You can see the thigh bone here, and this is the kind of muscle in the skin of the baby's leg. Well, in order to do a procedure on a fetus, you have to have the fetus holding still. You don't want to do a procedure on something that's a moving target. So how do you give anesthesia to the fetus? Well, you take a needle, poke it through the mother's abdominal wall, through the wall of the uterus, you find the thigh, and here you can see the anesthetic agent, that white spot there, being injected into the leg of the fetus. So essentially, we're giving this baby something to prevent it from feeling any pain, an analgesic, and we're also giving the baby something to prevent it from moving around so we can do the next part of the procedure. So now what you're going to see, again, this is the wall, the abdominal wall of the mother, this is the uterine wall, this is the chest wall of the fetus, and this is the fetus's heart. And what you're going to see here is a needle that's being passed from the abdominal wall of the mother, through the wall of the uterus, through the chest wall of the fetus, and into the cavity of the left ventricle of the heart. And here's Dr. Perry moving that needle, and here's the left ventricle, and you can see he's just poked through, and now the tip of this needle is sitting in the middle of the left ventricle in the fetus. Through that needle, I can now push a catheter, just the way I can do with an angioplasty catheter. In fact, the catheter they use here is the same one that we would use to do an angioplasty of your coronary arteries. The catheter is then passed across the blocked valve. The balloon is blown up, just as the example I showed you on the older child before, and essentially that valve is now popped open. And here's the catheter going across the valve, and then the balloon is being blown up right here. There you can see it being blown up, and suddenly the valve is open. This was the first successful procedure of this type that was done in the United States. This baby did get to term, and with serial ultrasounds, the left ventricle grew. There was no longer a blockage to blood flow. And in fact, the fetus has a unique healing capacity. If you do an operation on somebody, it causes a scar. If you do an operation on a 20-week fetus, and then the baby goes to term, and you look at the skin, there's no scar. Fetal healing is different. And this valve actually healed so nicely that when the baby was born, all the doctors who did this expected that the baby would need an open heart operation, at least to replace the abnormal valve. But the valve remodeled itself so nicely that, in fact, the baby did not need open heart surgery at birth. And there have been about 50 of these procedures done across the country right now, and probably a bit more than that in Europe. The success rate is still mixed. There certainly are some of these babies who don't survive the procedure, and this is still considered pretty experimental. But one day this may become the standard treatment, not to prevent heart disease totally, but to take a very severe heart condition and prevent it from developing and make it into a much more minor and easily treatable heart condition. Well, last but not least, I'd like to focus on this because, again, if you've been watching the news lately, you've seen one of our surgeons, Dr. Mohan Reddy, who did this procedure that was shown on CNN and a lot of the other networks. Sometimes babies are born prematurely, and sometimes those babies have serious heart defects. And up until recently, most of those babies died. Because if you can imagine, it's hard enough doing open heart surgery on a full-term 5 or 6 pound baby. How could you possibly do heart surgery on a 1 pound baby? Well, it takes a talented surgeon, a group of extraordinary talented nurses in the operating room, post-op care in our intensive care unit, but this baby's heart was essentially the size of a small grate. And using specialized catheters and technology, Dr. Reddy was able to repair this baby's heart. Baby recovered in our neonatal intensive care unit and is actually now back in Southern California and growing and feeding and doing well. So sometimes we can fix it in utero. If we can't fix it in utero, now at least we can fix it when the babies are born, even if they're born very small. I don't know that we'll ever be able to do open heart surgery in the same day unit. We certainly would like to. This is a little boy who actually had a heart transplant many years ago, and he just happened to be in the wrong crib. But look where we've gone over the last 50 years. 50 years ago, if you were born with a simple hole between the two upper chambers of your heart, it was a lethal diagnosis. Today, you don't even need to go to the operating room for us to correct that. That's how far we've come. We've come that far because of a very unique collaboration between doctors, clinicians who are treating patients, who come up with ideas, scientists working in the laboratory who come up with ideas, and a group of engineers who help realize some of the technologies that have resulted in the improvements in imaging and diagnosis, in treatment with new devices like stents and atrial septal occluders, of molecular biologists who come up with new tools to diagnose congenital heart disease, and of course some very inventive surgeons who are able to then put it all back together again. That's the kind of collaboration that makes medicine so exciting, and it's some of the collaboration that's going on at places like Stanford, where we have Silicon Valley right next door, the companies who are interested in moving these technologies forward, alongside with absolutely outstanding engineers, outstanding clinicians, and a whole team. Because to take care of these small kids, it doesn't just take one person. It's not just a surgeon. It's surgeon, cardiologist, anesthesiologist, nurses, social workers, respiratory therapists, a whole group of people who are dedicated to taking care of these kids and getting them out of the hospital and back to their families where they belong. And of course the families who no longer have to sit and become connected to a heart-lung machine in order to get their kids through surgery, but in fact who are just as important in making sure that their kids get through in one piece. And so that's what I have to say, and I'll be glad to answer any questions that you may have. The question is, what is non-compacting left ventricle? And the answer is, we don't know for sure, but it is a form of what we call cardiomyopathy. So when I've talked about kids with heart disease, I've tended to focus on those who have structural problems with the heart, a hole, a blocked valve, a missing heart chamber. There is another class of heart disease that are called cardiomyopathies. They are abnormalities of the heart muscle itself. Some cardiomyopathies result in the heart wall being very thin. The heart balloons out. And in that case, the heart muscle doesn't work very well, so the heart doesn't contract it doesn't squeeze very well. There are other cardiomyopathies where the heart muscle is very thick, and the heart actually can be functioning well, but the muscle is so thick that the heart can't fill with blood. We call those hypertrophic cardiomyopathies. Non-compaction is something that's a little bit halfway between the two. And what it looks like, essentially, is that the heart muscle, instead of being nice and smooth, has a lot of kind of hills and valleys. So it's somewhat thicker than normal, but it's got all these kind of serrated edge to it, and that results in an abnormality of the muscle function. And that abnormality can manifest in a number of different ways. Some of those children can actually have it in a mild form and be totally normal, and some patients are not diagnosed with the condition until they're in their 50s or 60s. There are other patients who have the same condition, at least it looks the same on an ultrasound, and they need a heart transplant by the time they're a year of age. And there's all variations in the middle. So is it one disease? I don't think so. It's probably a number of different diseases. And the best way I would say it is that when the heart muscle itself is diseased, it has three ways of responding. It can get thin and dilated, it can get thick and restricted in its motion, or it can get lumpy bumpy, which is essentially what the non-compaction looks like. And it probably is a result of maybe one of 10 or 15 different gene abnormalities, of which we just are not smart enough to know what they are. But it can present at any time and any age. And I have a family that I follow where the aunt has a very severe form and died at about age 30. The mother, who's in her 40s, has a moderate form and is on medication but doing well. And she has 5 children, and every one of the children have a very, very mild form of it at this point. But we don't know what's going to happen over time. Some of them may get sicker, some of them may not. It's a disease that we don't yet know enough about in order to be able to predict how a particular child is going to do, even within the same family where it can present at very different ages. So the question is, are all cases of the hypoplastic left heart syndrome, where the left side of the heart doesn't develop, are they all related to an inability of the blood to leave the left ventricle? Are they all due to a blockage of the aortic valve? And the answer is probably not. Some of them are actually probably due to abnormalities of blood entering the left ventricle. So if you have a blocked mitral valve, the valve that enters the left ventricle, you can develop a hypoplastic left heart syndrome. There are other abnormalities that can probably do it. I think blood flow is one explanation for what causes hypoplastic left heart, but it's not the only explanation. It's probably a combination of the genetics of the disease, which we don't fully understand, plus the blood flow, plus probably a number of other factors, which, again, we're just beginning to learn about. The question is, what about the availability of devices for children with heart disease compared to adults with heart disease? Because there are many fewer children with heart disease compared to adults. And it doesn't just extend to devices, it also extends to drugs. You know, heart disease is the #1 killer in this country. It far outstrips any other disease. We tend to, I mean, in fact, if you look at government funding for cancer research or AIDS research, it dwarfs the amount of money that's being spent on heart research, yet more people die of heart disease than of any other thing. Actually, 10 times as many women die of heart disease as die of breast cancer. Most people don't realize that. So there's an enormous amount of adults with heart disease. And so new drugs are always tried out on adults first. Sometimes they're never tried on children. The FDA actually remedied that a while ago with what's called the pediatric rule, which stated that if you had a drug that could possibly be used in children, it had to be tried in children, even if just to establish its safety. And so that's helped us a lot because it, in fact, got the drug companies to say, we're going to have to put some money into pediatric trials, and they got a benefit out of it. They could extend their patent by a period of time if they showed that the drug was either effective or not in children. The question is, what is the role for a technique called ECMO, which stands for extracorporeal membrane oxygenation, in management of kids with heart problems? So what ECMO is, essentially, is heart-lung bypass. It's the same exact technique that they use in the operating room to take over your circulation. So it consists of two components. It consists of a pump to pump the blood, and it consists of what's called a membrane oxygenator. It consists of something that substitutes for the lungs and allows the oxygen to be put into the blood so that it can then be delivered to the body. It turns out that that's the most complex piece of the equipment. And in fact, when Dr. Lillehei first invented the first heart-lung machine, the more complex part of what he had to do was to come up with the oxygenator circuit. The problem is blood is very sticky, and it sticks to the membranes in those circuits, tends to clog them up over time. So ECMO is a very temporary procedure. The longest we've ever had somebody on ECMO waiting for a heart transplant has been about 6 weeks, and it's a big struggle because it's a very invasive piece of equipment. Now, for open heart surgery, where the patient has a temporary setback and needs ECMO to support them for a couple of days until their heart function comes back, it's an excellent technique. And we probably do, my guess would be anywhere from 4 to 10 of those each year as part of our surgical program to help support children who need an extra day or two for their heart function to recover after a major heart operation. But for the longer-term patients, we really like the devices like the Berlin Heart, the one I showed you there, the left ventricular assist devices. The advantage of those is they don't have the oxygenator part, therefore they don't have that membrane that the blood sticks to, and they can be used for a much longer term. And again, some of those devices have been used for many years and actually have been approved now in adults as what we call destination therapy, which means if you're an adult patient and either you don't want a heart transplant or you have another disease or whatever and you're not a candidate for a transplant, you can actually now have one of these devices implanted as a permanent solution. And again, the longest living survivors now are about 4 or 5 years. They do have a little console. It's about the size of a typewriter and carry it around as like a shoulder pack. And many patients are able to live a moderately productive lifestyle with those devices, whether they're waiting for transplant or whether or not they're just home and getting a couple of extra years. Well, thank you for listening, and thank you for your good questions. And I hope that this was beneficial to you, and have a good evening.
The preceding program was brought to you by Stanford on iTunes U and is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at itunes.stanford.edu.